She's an American board-certified OBGYN.
She's the CEO of Jobs.mom.
We're women.
We're moms.
We're Muslims.
And we're talking about sex.
This is the Muslim Sex Podcast.
Welcome to the Muslim Sex Podcast. I'm Dr. Sadaf Lodhi.
And I'm Zabeen Mirza. This episode is about the second trimester of your pregnancy.
So before we get into it, the first thing that we want to make very clear is that we are not giving any type of religious or medical advice. So if you're having any concerns about your health, please speak with your medical provider.
And if you have any questions about your religion, please ask your friendly neighborhood religious leader. It's the Muslim Sex Podcast because we just happen to be two Muslim women who talk about sex. And today we're talking about the second trimester. So should we get started?
Yeah, let's.
So, we in our last episode, we talked about the first trimester. We talked about what to expect. We talked about, the newly pregnant. We talked about blood work and tests and what's normal and what's not normal and prenatal vitamins. And we talked about all that. So if you haven't listened to that episode, definitely listen to that episode. Lots of great information. This episode, we're talking about the second trimester. And in the second trimester, this is often called the honeymoon period because by now, a lot of the morning sickness, right, should have subsided. But that doesn't mean that there's not a lot going on. And there is a lot going on, and especially when we're talking about the testing side of things. So I know there's a number of tests that are conducted in the first trimester. There are also a number of tests that are conducted in the second trimester. So do you want to go a little bit into that, Sadaf, so the women listening know, it's easy for us to show up to these tests, but I don't know we necessarily fully understand what we're testing for.
Sure. So it has been also in the first trimester, we also do two tests that we need to also mention here, which is one is called the Non-Invasive Prenatal Testing, which is NIPT, and that typically can be done after 11 weeks. And what that tests for are genetic abnormalities, trisomy 13 and 18, and also Down syndrome. And in that test, actually, you can find out if you're having a boy or girl, if you want. Some patients want to know, others do not. But with that test, it's actually a blood test that is done from the mom's blood. And so from that test is where we can actually find out the sex, the gender of the fetus as well. Another test that's really important that's done in the first trimester is called the nuchal translucency, which is an ultrasound. And it's what it does is it takes a look at the back of the neck of the fetus, and we measure that height, and also it gives us an indication of whether or not the fetus is at risk for Down syndrome. And so those tests are typically done in the first trimester. In the second trimester, one of the most important things and one of the most fun things that patients look forward to is the anatomy ultrasound. And that's typically done at 20 weeks. And that's where we're able to check the heart, the lungs, the full anatomy of the fetus. And of course, in here, if for some reason, patients decided not to get the genetic testing done or the NIPT testing done in the beginning of their pregnancy, here on this ultrasound, they can figure out the gender of the fetus as well. And we take a look to see how well the baby's growing. And also we take a look at the placenta, the amount of fluid, and we make sure that everything looks the way it's supposed to look in terms of anatomy for the fetus. And it is a very important test. Also in the second trimester, we will continue to see patients every 4 weeks up until like 28 weeks, where we start seeing the patients every 2 weeks. And then that is, of course, as you know, is actually the third trimester. Something else that's done in the second trimester, and we kind of touched on it a little bit, was the glucose testing that happens. That typically that can happen anywhere between 24 and 28 weeks. And that's why I kind of mentioned about Rhogam. Rhogam, we always give at 28 weeks, but, we do the glucose testing between 24 and 28 weeks. And what we'll do is we'll give a 50-gram glucola load, a 50-gram, like it's that sugary drink. And then we have the moms have their blood work taken. And we take a look at the value. And if that value is elevated, there's a normal level that we have, usually around like 100 it's like 130. If it's a 1 hour, yeah, we usually use 130. And if it's higher than that, then we'll have you do a 3-hour glucose test and to check for diabetes in pregnancy. Pregnancy itself can make a woman that is typically not diabetic, it can cause her to have diabetes in pregnancy. And that's why we test for that. And the most important thing about it is that if a woman develops diabetes in pregnancy, she is at, before we used to say, when I was in residency, a 40% chance of developing diabetes later on in pregnancy. However, now they're saying that it's a 50% chance. So if somebody develops diabetes in pregnancy, they have a 50% chance of developing diabetes later on in life. So what some doctors have now called pregnancy is that it actually is kind of like a window into the future of that mom, which I think is a great way to look at it. Because if that woman develops, let's say she develops high blood pressure in pregnancy,
Yeah.
then she's at an increased risk of developing high blood pressure later on in life. If she develops diabetes in pregnancy, she's at risk for developing diabetes later on in life. So this should be an opportunity for physicians and for the moms that end up developing these diseases in pregnancy to kind of look at their lifestyle choices and what's going on to help modify any risk factors that they may have so that hopefully they don't develop those diseases later on in life. So that's really important.
And I'm having, PTSD flashbacks when you're talking about the sugar drink test, right? Because
Yeah,
it's
it's pretty
disgusting.
gross.
It's awful. It's really bad. And somebody thought that it would go down easier if you made it orange flavored or some other horrendous flavored, and it does not go easier. It does not, it just does not go down easy. It doesn't matter what flavor you put it in, right? And I struggled. I remember I took the short test and then I had to take the longer test, and I didn't have GD. But it was just a very unpleasant experience. But what about the women? What do you say to women who are concerned about the sugar drink itself? I know in recent years there's been a lot of talk about, is it safe? And, what do you tell these women?
Yeah. Well, what we typically tell them is that it's very important to do this test because that's the only way we can tell whether or not they're diabetic. Now, definitely there are women that refuse to do it and won't do it. And so then if that's the case, then we'll have them test their sugars 4 times a day, which I think is even worse, right? To see whether or not, I mean, if we think that there may be, at risk, like say they did that first 1 hour and it was elevated but they refuse to do the 3 hour, then we will have them check their sugars for at least a week or so to see whether or not they're diabetic. And then if those sugars are fine, then we won't we won't have them do anything else. However, what they're doing is they're checking for their values. So after a 1 hour eating, what you want to do is you want to check your blood glucose. And if it's higher than 130, then, we have to take a look at, see what they're eating and modify their diet. Now, if we consistently see that those values, let's say, are like in the 200s, then we definitely will advise them that it sounds like perhaps, and especially if they're fasting, let's say is 150, fasting first thing in the morning, they take their blood sugar and let's say it's like super high, then we automatically will assume that they're probably diabetic. And we'll have them start testing their blood sugars. And if they need to, then some doctors will use oral medications. But when I was in residency, we always use insulin to help manage diabetes in pregnancy. And that can be done with, your own OBGYN, or it can be done in conjunction with a high-risk doctor. And once a high-risk doctor gets involved, then, typically they'll start to monitor the patient's blood sugars pretty closely. as will a regular OBGYN. And we'll also do ultrasounds every 4 weeks to monitor the growth. And some of the important things to know about diabetes in pregnancy is that glucose crosses the placenta and so can result in very large babies.
Yeah.
Right. So and that's why we do the growth check with these ultrasounds, because we don't want that baby getting too big. And just like for a mom that is diabetic who then has to pee all the time, the baby does the same. And so the baby can accumulate a lot of fluid inside of that uterus, and which we call polyhydramnios. So these are things that we monitor and we look for. Also, if a woman is pre-diabetic, then again we'll check the growth, and sometimes those babies can be smaller because the placenta may not be getting as much perfusion, right, as much blood flow. And because the blood vessels may be affected in somebody that's been diabetic for a long time.
Yeah.
So also, I was going to say that at these visits we always check for blood pressure as well. And Zabeen, like I had mentioned before, if the blood pressure starts to go up after 20 weeks, then we consider that pregnancy induced hypertension, high blood pressure. And again, we always check for protein in the urine with each visit, and we worry about preeclampsia. And as preeclampsia is defined as high blood pressure after 20 weeks, as well as protein in the urine. So that's why we check for both things. And, different things will happen. Like if, for example, if somebody has a history of preeclampsia with their first baby, then we'll automatically put them on a baby aspirin starting at like 16 weeks throughout their pregnancy up until 36 weeks. And also, like I said, if we also take into account their previous pregnancy history, and if they have a history of preterm deliveries, right, or if they have a history of incompetent cervix, then we may suggest a cerclage, which is a stitch at the cervix that kind of keeps that pregnancy in. And that typically we place a cerclage if they have a history of what's called an incompetent cervix. So basically, they're not able to hold on to the pregnancy and they have what's called painless dilatation. And that's what a cerclage is used for. And so if it's a history indicated cerclage, usually that's done in the second trimester before, usually by 21 weeks, before 21 weeks, we'll do that. We'll put that cerclage in, or we'll measure the cervix. And if the cervix is measuring pretty small, then sometimes less than 1.5 centimeters, then a doctor may decide to put a cerclage in as well.
Okay. And again, these are all things that your medical provider is going to let you know for you and your individual case. So, if any last words before we wrap up here about the second trimester, how women should be taking care of themselves, what they should be looking out for?
No, I mean, at that ultrasound visit that they have, like I said, they'll go over where the placenta is located. And if the placenta is covering that cervix, I think we kind of mentioned it a little bit, but it may be that the patient has what's called the placenta previa. And sometimes those placentas will move up, and so that that placenta previa will have resolved. But if it doesn't, if it stays there, then the patient is definitely at risk for bleeding during the pregnancy. And the patient, if it never moves up, then the patient will require a C-section at the time of delivery at around 37 weeks.
Yeah. So I think the lesson here is stay aware of your own body. Definitely speak to your provider about anything that you feel is unusual or uncomfortable. And definitely, especially if you have a history, right, in previous pregnancies as well, of things like diabetes or previa, or have had complications and high risks, certainly seek out providers that are also high risk specialists. And as always, stay on top of your care. So, we're closing up here now. It has been, as always, informative and intimate. And for all of you, Sadaf wants to remind you that it is not medical advice. What should they do if they need medical advice, Sadaf? Where do they go?
Correct. Zabeen. So please see your healthcare provider for any concerns that you might have, especially when it comes to pregnancy.
Yep.
It's so important to speak to your own provider.
Yep. Speak to your provider. Keep having sex if it's allowed, right? That's what Sadaf said, the doctor says. And
Yes,
until
lots
next,
of sex.
lots of sex. And until next time, this is the Muslim Sex Podcast.